And I wanted to hand over now to the first of our really exciting presentations. So this presentation is about scaling a virtual ward model across the system in Maidstone and Tunbridge Wells. And we've got Naresh Nagalipalli, who is an advanced clinical practitioner in Maidstone and Tunbridge Wells Trust. And we've got Jonathan Lewis, who is Managing Director of Lucy UK. So over to you guys. Thanks.
Good afternoon, all. My name is Naresh. I'm advanced clinical practitioner in virtual wards, Maidstone, Tunbridge Wells, and NHS Trust. I'm here to talk about how the Maidstone, Tunbridge Wells, NHS acute virtual wards, which are innovative, tech-enabled, and patient-centered, scaling across the system to deliver hospital-level care at home. And also, I'll briefly want to talk about our future plans to advance a bit furthermore into the community. And our model is, it's 24/7 nurse-led hub, and we deliver clinical reviews, video consultations, and home visits from our acute model of virtual wards. We actually sit under the acute settings, not in the community. We come under the acute NHS Trust. And we use Lucy as a healthcare platform. This is effective and a user-friendly platform that we use to take care of our patients effectively at home. And under our service, we can deliver IV antibiotics and investigations at home, wound care, and we started with the respiratory pathway. Sorry. I think there's... So we started at the respiratory pathway, but we scaled into across 11 pathways now, including general medicine, surgery, orthopedics, hematology, and frailty, and so on. Sorry, there are a few slides are missing, but I'll talk about that. And what is unique about our model is this is a generalistic acute ward. It's not a particular one symptom specific or one condition specific, and it can accommodate high acuity patients compared to other virtual wards. So a brief difference is the typical virtual ward, they are low acuity, they take low acuity patients, single conditions like COPD or COVID or heart failure, and they have basic remote monitoring technologies and limited pathways. In contrast to that, the MTW acute virtual wards, they have like multi-specialty, like I mentioned, so many pathways, and it's 24/7 nurse-led, and we get the real-time data with the Lucy platform. And patients can upload their observations, and they can chat to us through the text and then video calls, and that will relay as just like, in-time information without any delays. And our wow factor is like, we are proud to say that we are multi-specialty acute virtual wards, and we take high acuity patients. And to give a brief numbers, like so far, we accommodated almost 2,000 plus patients, and my previous speaker talked about the bed delays and then bed days. We avoid around 7,200 plus bed days in the acute hospital with very less than 5% of escalations. That means like number of patients we have to bring back to hospital for admission, that is less than 5%, and 0 serious incidents. And talking about the cost, to maintain a patient with our healthcare platform, Lucy, under the virtual ward, it costs £33 per, just a day and night. It's around the rough figure, in an acute hospital, it's £350. So that speaks about like how much positive financial effects it can show by using the virtual wards. And the problems we solved is like our acute virtual wards played indirectly or directly to relieving the post-COVID pressures and high bed occupancies, ED delays, and then so on, like elective surgery. So by by emptying the acute hospital beds, we facilitated so much that the delays from the COVID time, they caught up, and then I'm proud to say that MTW ED is one of the best performing ED in the UK. What our families wanted is a safe alternative, for patients. For example, if they can stay at home and then get everything what they need safely, that's the dream for a patient. And that's what we are delivering at MTW NHS through our collaboration with Lucy. And as all of we know that there are some challenges initially. One is my previous speakers mentioned digital literacy, patients can use it or the staff can be trained for that. Sorry. So I'm a ACP from geriatric background. It is proud to say there is 102-year-old patient with Apple iPad 2024 model. She showed me how to download the app and then use it. So never assume or we take it as maybe it's not, the elderly people can't use it. No, they can use it, and then we are the example for that. And in terms of staff training, we conduct the training programs with the help of Lucy, and they're well trained, and then we are running a hub 24/7. They are all digital literate with this virtual ward and then the Lucy platform. And what about the scalability and then sustainability? That's one of the questions. But again, I'm proud to say that SBRI is doing a research on the trust to scale our referral systems and our SOPs and then our business model to spread across the NHS in UK. So it is working well in Kent. So I'm sure it will work in the other parts of the NHS. So our workforce, in each pathway has their named consultant, registrars, ACPs, pharmacists, and community teams. We closely collaborate with KCHFT, that's the Kent Community Health Foundation Trust, that's a community trust, which we use community nursing from that. And we closely work with Lucy to produce more and more pathways. And we work with ICB and other national engagement teams. As we all can see, we are well positioned to align with NHS at home and upcoming online hospital models. We are already delivering hospital level care at home, and we are improving. And in terms of interoperability, the pathways that were developed are so generic that, for example, there is a urology pathway, but you can also adapt to just pyelonephritis or catheter care. So these are quite user-friendly and then interoperable pathways that we have, which are well managed under Lucy platform. At the same time, they're well managed under our hub so that they can escalate the patients quite quickly and then effectively. So these are some strategies we are already implementing. So we are collaborated with KCHFT, and we have a step-up and step-down model with the community services so that we can take care of patients basing on their acuity levels. And also, we have close relationship with palliative team, SALTs, respiratory team, and then community dietitians. We do the referrals from acute settings to the community, and then so on, community to the acute setting, like step-down and step-up model, which we are implementing already. And our future projects are, at the moment, the particular area that is face-to-face reviews. If someone is unwell, we have to bring them to either ED or SDEC area to have a face-to-face review, and that is increasing the number of footprints to the hospital. So our next target is to have an ACP-led home visits, where service like bedside ultrasound can be delivered, so rule out DVTs and urine retentions, catheter care, and ruling out the hydronephrosis. So these services will enable to decrease the number of footprints to the hospital. And although we want to implement the virtual ward clinics. So where, for example, at the moment, we can only accommodate 3 times a day intravenous antibiotics. By having these virtual ward clinics, what we can accommodate is up to 4 times, and then we can take more patients and then deliver the care in the community. We are expanding in terms of the pathways. We are looking into maternity and pediatrics next specialty. Before I hand over to Jonathan, I would like to conclude with a statement. Our virtual wards at M2W NHS, open to change, ready to adapt, and eager to collaborate. With the patient at the heart of everything we do, our goal is to ease the pressure on healthcare system by safely delivering hospital-level care at home. Thank you.
Thank you. All I was going to quickly add, well, first I want to congratulate this gentleman here for rolling out remote monitoring across all of Pakistan in a week. Sounds unbelievable achievement. I simply wanted to say that you can think of virtual wards as a kind of system lubricant. In Maidstone and Tunbridge Wells, they reduce hospital capacity from, say, 95 to 91%, and what that allows is the system to flow. So even though virtual wards are only about 7% of NHS beds, they can make a profound difference. And the fact, I just wanted to pull out one more point. It talks about a 90% improvement in cost. If you do get virtual care right, you really can create those quantums of improvement at scale. So, for example, in Airedale, where we support a COPD hub, it's essentially a care coordination hub that manages people with either severe or very severe COPD. They manage to keep 99% of the people out of hospital, and they have a nurse-patient ratio of 1 to 300. So these models of care do exist, and if they can be scaled, it really will make a difference to how the NHS works. One piece of news perhaps about Lucy is we've now partnered with GraphNet, and GraphNet obviously has a shared care record and population health management system for about 20 million people. So theoretically, you could onboard millions of people onto remote monitoring pathways overnight, and you would see almost overnight a very significant improvement in the quality of the care across the NHS. So I think we exist in a situation now where the technology tools are there and ready to fundamentally change how care is delivered. Thank you very much.